My name is Rungapiromnan. I'm a PhD student at the University of Manchester, and I was the principal investigator on this new meta-analysis which examined the potential association between major adverse cardiovascular events and biologic therapies for the treatment of plaque psoriasis. Biologic therapies now have a major role in the treatment of severe plaque psoriasis. It has been speculated that these medicines, having anti-inflammatory effects, could influence the risk of developing cardiovascular disease in patients with plaque psoriasis. Recently, however, a higher rate of major adverse cardiovascular events was observed in patients with psoriasis receiving biologic in randomized controlled trials. This has raised a concern regarding whether anti-interleukin 12-23 agents could be associated with an increased risk of major adverse cardiovascular events. We carried out a systematic review and meta-analysis of all licensed biologic therapies to explore this possible association further. We searched for randomized controlled trials which reported adverse events among adult patients with plaque psoriasis who received at least one licensed dose of biologic therapies, conventional systematic therapy, or placebo during randomized control periods. We searched for a large number of databases to identify these trials, including the U.S. Food and Drug Administration and the European Medicine Agency websites, pharmaceutical company websites, and clinical trial register platforms. We compared the number of patients experiencing major adverse cardiovascular events in several ways. Firstly, a combined analysis considering exposure to any biologic therapies, and then stratified this analysis to consider separate biologic groups. For instance, anti-tumor necrosis factor and anti-interleukin 12-23 agents. It was also possible to compare any differences between licensed doses of secukinumab and adalimumab. Overall, 38 randomized controlled trials involving over 18,000 patients were included. No major adverse cardiovascular events were observed in 29 trials, while 9 randomized controlled trials reported 10 patients experiencing major adverse cardiovascular events. We found that biologic therapies were not significantly associated with the risk of major adverse cardiovascular events, and there were no significant differences between doses of secukinumab and adalimumab either. However, we were faced with a number of important limitations with the randomized controlled trial that we identified. Most of them had small sample sizes and short duration of randomized control exposure to treatment. Major adverse cardiovascular events are rare events and are likely to require longer periods of follow-up. In the future, well-designed observational studies which involve larger numbers of patients and longer durations of treatment exposure, reflecting clinical routine practice, are required in order to better examine the impact of biologic therapies on the risk of major adverse cardiovascular events in patients with plaque psoriasis.